So speaking of medical abortion, there's a pearl of excellence. Yeah. Do you do the pearls of excellence, bro? Or
I mean I look at them, but they're like a lot. There's like a lot of them, so I haven't
they're
had.
really helpful, man. They're really helpful, and
Yeah, yeah,
they're
yeah. The ones
yeah,
I looked at, they're very informative. But there's like a lot of them, so I haven't had a chance to go through all of them.
yeah. There's the one on medical like abortion. I just went through it like a few days ago, and I took some notes and stuff. So let me place you on that.
Yeah, sure.
But yeah, but where did it go? There we go. Medical abortion. What do you call it? Uh, can you do like medical like abortion through like a telemedicine visit? Like if you see a patient in the first trimester and she's stable and she doesn't want a pregnancy, is it okay to prescribe the medications if you're seeing her virtually?
Oh, that's ideally I would like to see her to confirm the pregnancy and to make sure she doesn't have like a topic. I will have to ask her like how far she is and all that stuff. I know outside of the country, like other countries, that's a possibility. Um, but for me, I would not give someone um, abortion pills unless I can physically see the evaluate the patient first.
That's a very good answer. All right, cool. And what regimen do you prescribe? Like, how do you prescribe? Uh,
So the where I practice the mifepristone is limited access. So in the I generally only prescribe misoprostol. Um, I depending on the how far they are. If they're in the first trimester, I usually do 800 micrograms sublingual um, times 2 doses. So every 24 hours, they can take up to two doses. Um, and then I usually before I also have them do blood work to check their beta ACG and also their RH status. And then I have them come back in 2 weeks to confirm if the medication worked.
very nice, nice. Okay. Uh, do you do like how far along like if someone's like if someone's in a situation where they tell you that they don't want to do their like blood work and they just want to get the medication uh like uh, like if you see them like if you see them for the visit and you examine them but they don't want to get the RH status done, would you still give them the medication, or would you
Yes, I
maybe
would.
like consider
Yeah,
giving?
I would still give them the medication as long as they're less than 10 weeks. The chance of a fetal maternal bleed is minimal, so less than 10 weeks, they should be okay. Get it? Yeah.
Okay, all right. And CMHE. And when you see them back, what do you like? How do you like evaluate them? Like, do you examine them? Do you
Yeah,
do
so
like,
I take their history, see if they had any large passing of blood clots or fetal parts. Um, and then also I do an ultrasound to evaluate the endometrium. If there's no gestational sac and the endometrium thickness is less than 3 centimeter, and that's a pretty good indication that the fetus has passed, or the POC has passed.
Do you do any blood work?
If I don't have any suspicion of retained products, I do not um, track their. Um, I do not do a blood work. However, usually I have them. I tell them like once, after about a month, I have them just do a urine pregnancy test at home just to make sure that it's negative.
Perfect. That's perfect. That's spot on. All right. And what's the failure rate for a medical termination or like a medical abortion if it's like more than 10 weeks?
Um, I know with the mifepristone, the success rate is higher. I believe it's around 80%, 80 to 90%. But without the mifepristone, the chance is slightly lower. I think about 10% less.
Okay. That's pretty good.
Yeah.
Nice. All right, cool. So, do you want me to do some like comments now, or do you want to keep going and then like do them at the end?
Let's do it at the end.
Okay, sounds good. All right, and then there's a case you have in your on your GYN list case,
Hmm.
case like 22, abnormal
Oh.
uterine bleeding, ovulatory dysfunction, IUD removal, removal. She had a steel IUD. Wow, what did it look like? What did the IUD look like?
Yeah, so these steel IUDs are like a circular IUD that's very commonly used in China. It's basically a steel coil, a
Ah,
circular steel coil. Yeah, there's no string attached to it, so a lot of these patients after first baby, it gets put into them, um, and then a lot of these patients have it for 10, 20 years. And now
wow.
that they're here, yeah, now that they're here, they understandably want it to be removed. It's very hard to remove it in the office because there is no string. So most of these patients, I have to take them to the OR for hysteroscopy, DNC, and IUD removal.
Okay. And was this patient symptomatic at all, or was she just like wanting it removed?
This patient, patient 22, you're talking about?
Yeah.
Yeah, so she actually does have abnormal uterine bleeding as well, on top of wanting to remove that IUD. So it's kind of so the procedure served two purposes. One is to evaluate her endometrium, and the other one's to remove the IUD. So.
Perfect. Perfect. And what types of like IUD do you do in your practice? Like, w when are they like indicated? What types do you know of? Yeah.
Yes. So we offer Marina IUD and the Paragard IUD, and the Skyla. So for the levonorgestrone containing IUDs, they can other than contraception, you can use them to for to I guess suppress the endometrium. You can use it to for suppression of bleeding if they have fibroids and they have bleeding. Um, you can use it for endometriosis. And for the Paragard, you can that one is also good for emergency contraceptions outside of just regular contraception.
What is the Paragard IUD made of?
The Paragard IUD is made out of copper.
And what's the mechanism of action of by which it acts as a contraceptive?
For the Paragard,
Yes.
it creates a hostile environment for the sperm and the eggs and the endometrium to make implantation and to make implantation uh, I guess difficult, and also I think that's the main mechanism of action for the Paragard.
Correct. And how and like how soon can you use it for like emergency contraception? Like for like how long?
5 days.
Correct. Okay, cool. And Livanor gestrel like IUDs, do you know of like other types besides the Mirena and the Skyla?
Yeah, so there's Liletta and Kylina.
Correct.
Um, yeah.
Do you know the dose of the hormones in them?
For Marina is 52 milligrams. For Liletta, it's also 52. Um, Kylina is 19.5 and Skylar is 13.5.
Wow, nice, dude. Awesome. Cool. Do you know the release rate of the Mirena for the first year and then by year five of the hormone?
Um, I can't remember the
Sure.
release rate. I know it does decrease after 5 years, but I don't know the exact number.
Cool. And let's say you had a patient with bleeding and you did like an IUD in the office, and then she came back complaining of like irregular bleeding and some cramping like in the office. And then when you like evaluated her, how would you evaluate this patient?
So, if the patient had recently had the IUD placed, I would be concerned for a displacement of the IUD. Also, pelvic or infections or like endometritis. Um, it could also be just the side effects of an IED. So for her, I would first do an ultrasound to confirm the placement of the IUD, make sure it's still in the endometrium, in the cavity. Um, I would uh, do a physical exam to see where the pain is coming from. Make sure that also make sure that through the ultrasound, make sure there's no abscesses in the adnexa or in her pelvis. If the if there's no suspicion for displacement or infection, I would tell her that sometimes it could be just a side effect of the of recently placing the IUD, and I would instruct her to take some ibuprofen and maybe watch it for 3 to 6 months and see if the side effects subside.
Okay. How does Levonorgestrel gestural IUD work? Like, what's did you say? I think you said that it thins out the endometrial lining.
Oh, you said that, but yes, it
Okay.
does. Yeah, it works It also does the. It also can prevent sperm motility, but it also thinks out the endometrium, and I think it also can potentially suppress ovulation as well.
Okay. All right. And let's say, and so this is how it works as like a contraceptive. Like, what's the mechanism? Like, like you said, how the Paragard, like IUD works. The like mechanism of action. What's the mechanism of action by which the Mirena
Oh,
IUD prevents birth or
oh,
like a
for
pregnancy?
contraception.
Contraception.
I mean, they, I mean, all these can, they all can prevent contraception, but um, I know the suppression is not um, like very effective. That's not the main mechanism for which it's for contraception. But I know that it can sometimes it can suppress sometimes it can suppress ovulation, but the main mechanism of action for the contraception part is the thinning of the endometrium and also uh, decrease, I guess, survivability and the mobility of sperms.
Okay, good. So let's say you had a that patient with pain that that she had like after you placed her like IUD in the office and you did the ultrasound and it looked like it's low in the cavity but not completely out, like not at the cervix. How would you manage that? Would you like remove it since it's not like adjacent to the fundus, or would you do something else?
If it's not, if the if the IUD itself is not protruding out of the cervix, I would not remove it. I will counsel the patient that even though it's not in the exact, not at the fundus, it's still working as intended,
Good,
um,
good.
and we can still just leave it. Um, yeah.
Good. All right. And if you remove it, how would you counsel the patient? Is she like if she tells you no, I don't want it, I want you to remove it because it's causing a lot of pain? How would you counsel her about the removal? Uh, is she a good candidate to get another IUD or no?
Um, if she's really adamant about removing, I would remove it. If she, I would not. Well, I can suggest maybe trying the smaller IUD like the Skyla to see if that helps with her pain. But I would not put the exact same one in her.
Okay, but it's not like a contraindication for another one, right? If it
No.
was placed. Okay, good, good, good. How many minutes are we in? Okay, I think we have 5 minutes left. A nice job. Do you wanna go over the comments and then you can like start asking me?
Yeah, sure. Sounds good.
All right, good. So the medical abortion, I think you did very well. Talking about like Mephi, like Prestone. Yeah. So so if you read the Pearl, there's the FDA approved regimen, and then there's the World Health
Uh-huh.
uh, like organization regimen, but they're both the same pretty much. So what it says is you can give like Miffy Prestone 200 milligrams orally once, and then followed by misoprostol either vaginally, sublingually, or buccally every 6 to 48 hours. So yeah, so I think you got that right. And then in the Pearl, they say This is a new pearl. This is like the first one that you will see in the list. So I think it
Oh,
might
okay.
be like relevant. And they also
Yeah.
say it decreases the risk. What are they saying? They're saying it's appropriate via telemedicine. It's like as effective as like in-person visits and is safe, and is like associated with a like high patient satisfaction. However, you need to prove like you need to have some sort of certainty about how the patient was dated, rule out an ectopic, things like that.
Well,
Things
yeah,
you,
exactly. You can't.
yeah.
So that's why I'm like, okay.
Right. So it's
Then,
a so it's like a tricky point. Like they say it's appropriate if you have like a reasonable amount of confidence that this is not an ectopic and the patient's reliable and things like that. But if
yeah.
there's a concern, you should rule that out first, of course. And
Yeah, how
then
would you rule that out without seeing the patient? I don't.
without seeing the people, like if you saw someone who works with you and now she's seeing you for like a tele visit so you can like prescribe her the medicine, like
Okay.
for example, yeah, this
Yeah,
is a
yeah.
scenario,
Okay. That's
possible
fine.
scenario.
Okay.
And then the 2020 ACOG stated that the gestational age dating based on last menstrual period without the ultrasound is acceptable and approved for medical abortion up to 70 days. I think we spoke about that last time, and the RH and the fetal
Uh-huh.
red blood cells and things like that. And I think
Right.
you did a good job saying that you can do it. All right. And you see them back in 1 to 2 weeks. You can do a telemedicine. They can do a home UPT in 4 weeks. That's spot on. And if you see them in the office, you can do a beta, and if it drops by 80% or more in 1 week, that indicates success. If you want, that's an
Ah,
option.
okay.
And then the failure rate is like 0.5% if they're less than 7 weeks, and like
Half a
three point
percent? Like point five
four
percent?
0.5%. That's the
Wow.
failure rate.
That's very
If they're
low.
less than 7 weeks, yeah. And if
Huh.
they're if they're 10 weeks or more, actually, if they're less than 10 weeks, so 7 to 10 weeks is 3.4%, which is a little bit higher.
Is this without or with the mifeprostone though? Do you
Oh,
know?
I don't know. I
It
think
didn't
this is
say.
with the mifeprostone.
Okay.
Yeah, yeah.
You said 3.5%?
3.4 if they're 7 to 10,
Uh,
and like 0.5 if they're less than 7 weeks. But the Pearl had only the like mifeprostone. I guess they said you could also use misoprostol only 800 every 3 hours for like 3 doses if you don't have the like the mifi like
mifepristone?
prostone.
Mm-hmm.
Yeah, but I'm not sure. They didn't say whether this is with or without the mifeprostone. That's something they
So,
did.
a ACOG has a I guess a public practice bulletin. And in the practice bulletin, they said that without the mifeprostone, it's 70% by day 3. And then about 80% if you have given 2 doses. Um, yeah.
70% success
Yeah, success rate.
without the mifeprostone. Okay.
Right, right.
Okay. And with it, it's like 10% higher, like 80% or something.
Yeah, 80 to 90% with with the mifepristone.
All right. I'll look that up. But yeah, sounds good. Sounds like right. Like, doesn't sound abnormal. All right. Yeah, but this is like a new pearl. I think the pearls of excellence are great because they're like quick to go through, and
Yeah,
I
they're
know
very
there's a
short.
lot of them. Yeah, but they're very short and they're very informative. Like you need
Mm-hmm.
to Like you learn a lot from reading them. All right, and I think the part with the IUD, there's a really good Pearl too, and I think there's also like ACOG, a committee opinion 672. That's really good for that, and it talks about like some of the challenges with like using LARCs and stuff. So it said the copper IUD is most effective when it's located in the fundus. So if it's not located in the fundus on a follow-up exam, like if it's low in the cavity, you should remove it because it may result, or like there's when malpositioned because of the increased risk of contraceptive failure. Okay,
Oh,
so
interesting.
yeah, but the Mirena IUD, it can be left in place because like even if it's located in the lower uterine segment, there's like uh, the local effect of like the hormones,
Uh-huh.
you know, and it's still working even if it's slow in the cavity. But if it's at the in the like in the cervical canal, you should remove it. All right,
Oh
either
wait,
one.
does that IUD, Marina IUD, increase the cervical mucus viscosity?
Thickens the yes, thickens the cervical mucus, and it
Oh, okay.
also slows down the tubal peristalsis a little bit,
Oh, okay.
and and it thins out the endometrium. I think the copper is like toxic to sperm,
Yeah.
so it slows down sperm motility, and it creates like a hostile environment, like you said, for like implantation. So it's less likely to happen. And then and you can
Does
use it
does
up to 5 days, like you said, for emergency
does
contraception.
uh does the Marina does it have ovarian suppression or ovulation suppression?
No, I don't think it does. I think Depo has like ovulation suppression, like, but I don't think the Mirena suppresses ovulation. I think it can cause like a side effect of cysts sometimes, but I don't think it suppresses ovulation.
Okay.
Not sure. Yeah, I'm pretty sure it doesn't. Because I use a lot. All my case list is Mirena.
Oh, you better know it.
Yeah, exactly. And then what do you call it? If it's in the cervix, you should remove it. And sometimes when you follow up with the patients with like the IUDs low in the cavity, like if they have like a Mirena that's like low in the cavity, when you rescan them, sometimes the IUD can like move back to the fundus, and that is because of the uterine contractility. You know, like the muscles move it back in place. So that's cool.
Uh-huh.
And then, if you have a history of malposition or an expulsion of an IUD, this is not a contraindication for like another IUD insertion. And the recurrence rate of a malposition is not known. We don't know what's the recurrence rate of that. And then the
Oh,
complication.
what about the Oh, go ahead. Complication. Talking about.
So when you remove an IUD, there are some like potential complications. Uh,
When you're removing it?
yeah, so this is what the Pearl said. It says there are several uh, potential complications, and mainly the risk of. They were speaking about the risk of like unintended pregnancy, because when you remove it, you rarely replace it with like another reliable birth control method.
Mm.
So like they tell you this is the conversation that you need to have with the patient. You need to like explain to them, even with the IUD low in the cavity, the risk of like if we remove it, the risk of an unintended pregnancy is even higher than like the risk of contraceptive failure, and that's what
Mm.
they need to know, and that's what they speak about. And so that was a cool point, I think.
Mm-hmm.
But all right, yeah, and there
Oh,
was another pearl. Yeah.
uh, I was gonna ask you, like, cause I was talking about like the pain, and then like Because you were
Like the
asking me.
smaller one?
No, no, the ping with the IUD inside. And then you were asking me about like the differentials. Because I mentioned like, oh, like it could be like infection,
Right.
or like it may be like a endometritis or something. But how would you like like evaluate that, or like what test would you do
Yeah.
to? You can't
Yeah.
really.
Yeah, I think what you said was like correct. Like it can be like an STI, it can be an infection, it can be a UTI. Someone has pain, it can be anything really. But I think you shouldn't have said to rule out an abscess or something, because I think that is that is something that you should have like checked for before you did the IUD. Like if someone has an abscess and they're sick and they're having fevers and febrile and a white count and stuff, maybe they shouldn't have gotten the IUD. You know what I mean?
Yeah.
Yeah,
Yeah.
but I think the like differential is appropriate. Sometimes patients have like a lot of pain for like 3 to 6 months after the IUD, and then it gets better. So I think that like you answered it well. Um, and the I think the differential can be a little bit like broader. Like if she had pain and some bleeding with an IUD, I think we also need to like rule out a pregnancy. Maybe she has an ectopic, or maybe she has like something else going on. But I think with these differential like questions, like the like bigger you go, like the more you show that you're starting very general, like you really don't know what's going on and you're really working this patient up. And then once they hear the differential that they want to like ask you about, that's what they will focus on. But you could have said like I could get a urine like HCG. I would examine the patient, see if she's tender, see if she's bleeding, see if she has any rebound tenderness or like rigidity or guarding. What are her vitals? What's her like general appearance? What's the color and the feel of her skin? Is she sweaty and cold? All these
Yeah.
things.
Yeah. Yeah.
Just uh, like uh, like they give you points because like it shows that that it can be anything, and you just need to find out which one it is.
Oh,
Uh,
did you do you have to know like the rate of you know how sometimes it's like in the belly? Oh, I don't
oh,
know
like a
I don't know what you.
perforation.
Yeah. I guess it's a perforation.
Yeah.
But sometimes it just
Like
migrates.
an IUD, yeah,
Yeah.
like a migrated IUD.
Yeah. Well, do you know the rate of that, or do you
I
know?
think I think it's really low. I think it's like less than 1%, but I'm not sure of the exact number. Like the perforation when you insert it in the office. I think when you do it in the operating room, it might be a little bit higher because like the patient's asleep and like she can't feel pain and things like that. But I'm not sure. I have to look that up. I don't
Yeah,
know
because
the
I couldn't
number.
find it. I couldn't find it anywhere.
Are you gonna find one? I
Mm-mm.
think I think you might find it on like up to date or something.
No,
But
I look. I
oh, you did?
I look on up to date and I couldn't find it. Because it's
Ah.
not perforation. Because like you know how sometimes like after a few years they come back and they're like, oh, I don't feel my string or something. Like it's
Yeah.
not, you didn't perf during the insertion. It's like a couple years already.
Yeah,
So
interesting.
yeah, I don't
Yeah.
know, but
Yeah, there's like something that I read that they found like plastic in like someone's heart like in an like autopsy or something, and like oh yeah, man, it's crazy.
yeah, it's
Medicine is
crazy.
just full of these things.
All right, all
All right,
right.
man,
So
dude,
let's
I'm ready.
go. All right, let's go through yours. Hold on. Let me pull up your stuff.
Baby. Okay.
Questions. All right. I have quite a few for you.
Uh,
Okay, so let's
we're doing Q.
see. Yeah, Chihuahuan. Uh-huh. All right. Well, speaking of missed IUDs, tell me about number one.
Number one, yeah. So this is a patient who is a was a 19-year-old nullip. She had an exam with one of my colleagues in the office, and she had like an IUD placed a few weeks before that visit, and she showed up for her follow-up visit, and then she had an exam and they couldn't see like the strings of the IUD and on the speculum exam, and then she had like an ultrasound that showed the IUD was not in the uterus, and I believe she got also plain pelvic a plain pelvic X-ray that showed the IUD was in the pelvis. So I saw her in the office and I counseled her about the surgery, and she refused a pelvic exam during my the time that I saw her in the office. She stated that she went through a lot of discomfort with her with her prior exam, and she didn't want to have a similar experience, and she just elected to go to the operating room to have a surgery. This was a planned uh, uh, laparoscopy with removal of a missed IUD from the pelvis, because the assumption was that the IUD perforated, as it wasn't seen in the uterus, but it was still seen in the pelvis. However, after the patient went like under anesthesia, uh, I proceeded to like evaluate her systematically, and I always perform a bimanual exam for patients while they are under anesthesia. If they are, especially if they are undergoing a surgery on the uterus, to like evaluate the size and the degree of the flexion of the uterus, and how big is it? Is it mobile? And to get a better feel of the exam while the patient is has a relaxed lower abdominal muscle under anesthesia. And while I was examining her, I could feel the strings of the IUD in the vagina, and I just pulled it out. And we didn't perform the laparoscopy.
So, so it was still in the vagina.
Yes, it was. Yes, it was in the vagina.
Okay, so I guess your colleague just missed it.
I guess so. Yes.
Interesting. Okay. Patient number two. How do you evaluate stress incontinence for this patient?
So for stress urinary incontinence, I perform a history and a physical exam in the office. During my history, I want to know how many times the patient was pregnant, how many deliveries did she have, were they vaginal or C-section, how are her symptoms like? Are they are they continuous leakage of urine, or is it something that is exacerbated by performing a Valsalva maneuver, like coughing, sneezing, or laughing? I would also evaluate the patient for I would inquire about her history of diabetes, or a possible neuropathy, or or a possible a neurological disease like multiple sclerosis, for example. And then following that, I would also evaluate what the patient's medications are, if she's a smoker, if she has asthma, because these all can lead to the symptoms of stress urinary incontinence
Tell
or
tell me about tell me about how do you examine her?
so when I examine the patient, I examine the patient in the dorsal lithotomy position first. I instruct the patient to take a deep breath and then cough, and then I evaluate for the degree of prolapse, if any, and I also do that to see to check if the patient has a cough stress uh, reflex. I also perform post-void residual urine, which is done by instructing the patient to void and then performing an ultrasound scan to evaluate for the volume in the urine that is left in the bladder following the patient's void, and then I would also perform a Q-tip test and that is to test for urethral hypermobility by using a lubricated Q-tip and gently placing it into the urethra, and then I would ask the patient to cough, and I would evaluate the degree of the excursion of the angle, whether it's 30 degrees or not. If it's more than 30 degrees, uh, it's a positive test, and it would indicate urethral hypermobility. Uh,
Okay, that's
that,
good. Tell me about this anterior wall hematoma.
So the patient, following her surgery on the second day post-op, she was complaining of a lot of pain and discomfort, and she started to develop uh, uh, this like this like ecchymosis on the abdominal wall, this like bruising. On exam, it appeared to be diffuse, warm to touch, but it was more superficial. However, the patient's vital signs showed some like instability, such as tachycardia in the 100s to 1 teens, and she was complaining of some like orthostatic symptoms as well. So the decision was made to transfuse her 2 units of blood.
This
Secondary
is what
to
day? What day is this post op?
this was the second day post op.
Okay, so patient is still in the hospital.
Yes, she stayed in the hospital for 5 nights.
Okay, I continue.
And then she received the blood transfusion, and then after and then she was also like watched for like 2 more days following the blood transfusion, and then uh, we started seeing that the patient's symptoms were like improving with like conservative managements such as oral pain medications, ice packs, and she was no longer vitally unstable. So it was appropriate to discharge her home and follow up on the hematoma outpatient, and it did improve as well during outpatient follow.
Did you mention any imaging?
I did some imaging, but I didn't mention it when you were asking me now.
Okay, what type of imaging?
I got a CT scan of the abdomen and the pelvis with and without contrast, and it showed a diffuse hematoma, or like a diffuse heterogeneous mass within the subcutaneous layer of the lower abdominal wall, and it
Okay.
wasn't and there was no and there was no precise source of bleeding. There was no vessel that could be like embolized. It was more of a diffuse pattern. And when I spoke to the interventional radiologist, they didn't recommend. They did not recommend performing any procedure because there was no bleeding vessel to embolize.
Okay. Um, Patient number 4. You said AUB. Is that an I?
That is an I.
Okay. What is an I? AUBI.
Iatrogenic.
Okay. What does that mean?
It means the patient has abnormal uterine bleeding uh, uh, due to and an intervention that was done by a medical care provider, either like IUD insertion, surgery, for example, like a cold knife cone, or for example, hormonal contraception pills can also cause, or like or like hormonal therapy can cause like abnormal uterine bleeding sometimes.
What is a IUB? Um, I'm assuming you're using the palm cone.
Yes,
Okay.
AUB is short. AUB is short for abnormal uterine bleeding,
Uh-huh.
mm, which is defined as bleeding from the uterus that is abnormal in duration, uh, frequency, volume, regularity, and it is severe enough to cause symptoms to the patient, and for a duration of 6 months or more.
Okay. So what is the normal period then?
A normal period would range. I mean, it changes from patient to patient, of course, but on average, a normal period would be 7 days in duration. Uh, um, Give or take 2 days on top of that. And usually patients the average blood loss the average volume of blood loss during a normal period would be somewhere around 80 cc's, and uh, it usually it occurs uh, at regular predictable frequencies, or a regular predictable duration of an average of 28 days, give or take 5 days. So either uh, 23 to 32 days.
Okay. Let's move on. Patient number 5. Um, Patient number 5. Let me see. Uh, Number 6.
Sure.
This patient has an arcuate uterus. How do you diagnose an arcuate uterus?
So I believe the gold standard, or the recommendation to diagnose an arcuate uterus is using a combination of 3D ultrasonography as well as magnetic resonance resonance imaging. I believe the what we look for during these imaging studies is an indentation in the wall of the fundus that is less than 1 centimeters, and we also evaluate for the angle between the uterine cornua or corneae, and that angle needs to be less than 90 degrees. And arcuate uterus was thought to be one of the congenital uterine one of the congenital genital tract anomalies, and it was thought that it was associated with adverse pregnancy outcomes. However, that is no longer supported, and arcuate uterus is considered to be a normal variant of the genital tract anatomy.
So how is it different from a didelphys? Not didelphys, a bicornuate.
So a so a bicornuate uterus is one of the congenital genital tract malformations, and it occurs due to failure of complete fusion between the two Mullerian ducts during embryogenesis, and usually the patient has one cervix with a bicornuate uterus with two uterine horns or two uterine cavities with a thick intervening wall in between, and that wall represents incomplete the portion that didn't completely fuse between the two lateral uterine cavities.
Okay, so patient number 9 had a didelphys
Yeah.
uterus. Um, so it says that your hysteroscopy was um, your first attempt failed, and then you had a repeat hysteroscopy, and the second time it worked.
Uh,
Um,
oh no, I think what I was trying to say is that this patient needed to go to the operating room on two occasions because with the first procedure, we were very close to reaching the fluid, the limit of the fluid deficit, and I was only able to sample one of her uteri at that time, and I couldn't go over that deficit. So I elected to terminate the procedure, and then I was able to reschedule the patient for a repeat hysteroscopy of the contralateral cavity in a few weeks when it was safe to repeat the procedure.
I see. So this one has AUBN. What is N?
So N stands for not otherwise specified. She didn't have any cause of her abnormal uterine bleeding as far as I was able to I was able to evaluate her in the office. She didn't have any structural abnormalities. She didn't have any symptoms of anovulation uh, mm, or uh, or or endometrial disease. At one point, she was on anticoagulation for her history of venous thromboembolism. However, she has been off of anti coagulation for about a year since I saw her. Since when I started seeing her, so I couldn't identify a cause for her abnormal uterine bleeding at the time she was evaluated in the office.
So you mentioned that she has no symptoms of an ovulation. What are the symptoms of an ovulation?
So those would be irregular menstruation or irregular bleeding patterns. Patients complain of a lot of of erratic and irregular bleeding irregular uh, at irregular intervals. I would, and this is usually also associated with, classically associated with obesity and symptoms of hyper of hyperandrogenism. Uh, and that is the spectrum, or what we call PCO, or what is known as mm, what is known as PCOS. There are some other causes of anovulation, most notably around the ages of perimenarche or perimenopause, as the hypothalamic pituitary ovarian axis is still not completely developed and functional, and there's some degree of an ovulation during these years as well.
Okay. All right. Let's stop there.
That's it.
Uh, yep.
All right.
Um,
How did I do, my dude?
no,
All
pretty good, pretty good.
right. Thanks.
Yeah. I threw some
I think it was better than last
curveballs
time.
at you, huh?
You did actually. That was so good.
Yeah.
Yeah.
No, no, you
Yeah.
did good. You did good. All right. So let's go over um number one. But oh yeah, number one is interesting, huh? Your partner just didn't
Yeah,
find it.
dude.
That's crazy.
Thank God I didn't scope her. That would
I
have been a
know that would have been
yeah,
bad.
yeah. That would have been bad. Yeah. You're right.
That's funny. All right, so patient number two, stress urinary incontinence. Do you actually do the Q-tip test?
No, man. I don't do anything. I just do like the cough stress test, and if it's positive, I just send her to see like a urogyne or like urology, and then they evaluate her. They do everything, and then they tell me, oh yeah, we need to do a tape at the time of hysterectomy, or we need to do like a sacrocolpopexy,
Uh-huh.
and then we schedule the case together, and I do the hysterectomy, and then they do what they need to do, and that's it.
Ah, yeah. Yeah, 'cause I mean, I don't do it either, but I guess Exam
Yeah.
Pro was like, dude, you gotta do all that stuff. Like,
Yeah, no, that's important to like articulate, that you know what you need to do, but and that's why you tell them what you do, but
yeah,
they
I
know you
know.
don't do it properly. They know. They probably know that more than us. Yeah, it's
Yeah.
fine.
Um, but also I think you can say like, oh, you can say like you retrograde the fill the bladder.
For
Um,
the hyptometrics or
yeah, for no for the PVR, and you can use the
straight cat.
the stray cat as a guide for the Q-tip test, because you can use that as a,
Oh
you know,
yeah.
so that way you just do one procedure and you evaluate
Mhm.
both PVR and the mobility too.
And didn't they
So
say that during the course? Yeah,
I
they
think they
said
did
that.
too. Yeah, they said that.
Right.
And then I would just probably know like your anatomy really well for your anterior wall hematoma, because
Mhm.
I was about to ask you like what are the layers of the anterior abdominal wall?
Thank God you didn't. It's good.
Yeah, but
Yeah.
I would, cause it's on your thing, so you have to know it.
All right.
Um, and then we talked about the iatrogenic. I think that was pretty good. The answer you gave. Um, do you know what AUBE is for?
Endometrial. Endometrial.
Endometrial, right? But what does that mean? Like what?
Like endometritis, endometrial inflammation. It's a vague
Yeah,
category.
exactly.
Like I never use that category when I don't know how to diagnose. It's like there's some of the really old physicians tell you, oh, every patient complaining of abnormal like uterine bleeding where will like have some degree of like endometritis, chronic endometritis, and that's when you do like a biopsy, or when you look at the histology, there's some lymphocytes in the endometrium, and that's how you
Mm-hmm.
really diagnose it. But what's the value of it? Like, what are you gonna do? Are you
Yeah.
gonna like you
Yeah.
it's gonna like it's not going to change your management in any way. You
Yeah.
still need what you do normally,
Mm-hmm. No, yeah, yeah. I mean, that's as long as you know, because some people, I think some people get it confused with endometrial hyperplasia because they think that's what the E stands
Oh
for,
no,
like
that's
hyperplasia. Yeah,
ovulatory, I think. Yeah.
yeah. So that's M, the endometrial
Or
hyperplasia,
and
essentially.
yeah,
Yeah.
you're right. Yeah, yeah.
Um. Okay. And then the arcuate uterus, I think you said pretty
I
well.
just read it. Yeah, I just read
Oh,
on
you just
this.
read it?
Yeah,
All
I was
right.
like,
There you
yeah.
go. Yeah, so I remember it's like the less than 1 centimeter, and then the angle is actually greater than 90
Greater
degree.
than that.
Yeah,
Okay.
because you want because if it goes deeper, then it's less than 90, right? So
Oh,
if it's not as deep, then it's greater than 90. Um, yeah, and then that's the difference between arcuate versus
Bicor.
a bicornuate, right? It's more than 1 centimeter and greater than 90-degree angle.
Cool.
Um, yeah. And then the um, patient number 9. Yeah. So that was a good that you explained that you did one side one time and then the other side the other time.
Right.
Yeah. Because I was like, oh, what
What
was
happened?
what was the difference? Like, why did you do it
Right.
twice? Yeah,
Right.
but no, yeah, you just have to explain it.
Yeah.
Uh, okay, and then I think I asked you about the M. Wait,
Right.
which one is that one?
And
Oh, the
that's the
N.
9. Yeah.
Yeah, so you mentioned something about an ovulation, and then there's like signs and symptoms. I mean, AUB itself could be a sign of ovulatory dysfunction. So
Right.
it's gonna be hard to know which one it is, um, especially since she's 31. Is she like obese or something, or not
She
obese?
wasn't. Oh, no, she was like a little bit overweight, but not like her BMI wasn't more than 30. No.
Okay. So I don't know if you need to think of a better reason for why you put her as an N versus something else like an O. Cause like how would you know if it's not an O?
Mm. Mm.
Because like
Uh,
you could have no risk factors. Like she could be totally like a normal person and she could still have ovulatory dysfunction at 31, right?
she doesn't
So
have she doesn't have to have like PCOS, I guess, for
no,
that.
you don't have to have PCOS to have ovulatory dysfunction. You can still
Right.
have it, right? So just
Yeah, that's a good point. Yeah.
yeah, you could just think about it. Somehow you have to defend why you put as N. Because I don't think
Right.
a lot of things are under N.
No, there's not actually any
Yeah.
like I think the hormonal ones, like maybe hyperthyroidism or something, because there's no like endocrine classification or something for like endocrinal diseases or
Well,
like.
that will fall under ovulatory dysfunction.
Oh, it would be.
Yeah, I think so. Because
Yeah.
it's causing your ovulation to be messed up. So that's why you're
Mhm.
not having a period.
Yeah.
So yeah, so look into that, like, um, so you can defend that better.
Right, right, right.
Yeah. Um, I
I
mean,
have
I
someone on
think
my
that's.
case list on my office case list with hyperthyroidism, and I put her like AUBN, and then do AUBO. So
Oh,
yeah,
I
so
mean,
I'm gonna have
I could
to.
be wrong.
No, no,
Maybe you
I just
can,
have to like look into that more. But
yeah, just look into it more, and you let me know too, because I would like to
yeah,
know as well.
Sure. Yeah.
Um, but yeah, and I can also look into it a little bit more too.
Sure.
Um, yeah, I think that's it. So, what do you want to do? You want to keep going, or you're done for the day?
Yeah. I think we can keep going if you want to keep quizzing me. I mean, I'm good. I can keep going. Yeah.
All right. Sure. So I have a few more questions, anyways.
Sure.
Let's see. Uh, 12. Let me see. Okay. So, patient number 12. Why was she on Magistral?
I believe the patient was referred to see me for a surgical consult by a colleague, and I think she was complaining of a lot of bleeding at the time, and I think that was started by my colleague as a temporizing measure until she was able to see me and speak about a possible surgical intervention to manage her submucosal myoma.
Okay. Um, Patient number 15. Let's see. So you did a myomectomy. You said unsuccessful conservative management. What conservative management did you do for this patient?
So I think we tried some hormonal treatment for her. I think she had her laparoscopic uh, myomectomy a few years back, and then she had Levonorgestrel gestral IUD inserted following in the uterine cavity following that procedure. And at the time that I saw her, uh, the IUD was already removed because the patient desired a pregnancy, and she desired to become pregnant with her partner. So she wasn't also agreeable with restarting any form of hormonal contraception, like intramuscular depo hydroxyprogesterone acetate or combined oral contraceptive pills. However, she did have a Levonorgestrel IUD for the management, and she didn't want to have it anymore.
Okay. Um, what are some of the causes of a secondary infertility?
So there are some male factors and female factors, of course, and there are some unexplained causes. The male factors are diagnosed or are evaluated by a semen analysis, and those represent about 30% of causes of secondary infertility. The female causes they are responsible for 30% of of infertility cases as well, and they can be due to problems with the fallopian tubes, with like the uterine cavity, with like ovulation. There can be a problem with the general endocrine status of the patient as well. If she has, for example, uncontrolled diabetes or something else like hyperprolactinemia, for example, or uncontrolled thyroid disease, and also the unexplained the unexplained causes account for about 30% of the other 30% of the causes, and I believe 5%, 5 to 10% of causes are not known.
Okay. Uh, let's see. Alright, so patient number 17. Patient number 17. You said this patient had a thickened endometrium. What constitute as a thickened endometrium for a premenopausal woman?
So the ultrasound, the thickness of the endometrium uh, on on ultrasonographic like imaging in pre-menopausal patients is not reliable. However, it can be suggestive of some lesions in the endometrium, such as endometrial polyps or fibroids uh, or some sort of endometrial pathology. However, it's not recommended to, uh, as 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 a reliable measure or a reliable parameter to measure the thickness of the endometrium in a premenopausal patient using the transvaginal ultrasound.
Okay. And patient 19. Uh, why didn't you do a in office endometrial biopsy instead of taking her to the OR?
To the operating room. I
Mm-hmm.
think like I counseled the patient about her management options. I spoke to her that we can either do the procedure here, like in the office, where I perform an endometrial biopsy and then perform the IUD insertion following that. But I think the patient declined, and she elected to have the procedure done in the hospital under anesthesia to avoid the discomfort associated with the with the biopsy and IUD insertion in the office.
Okay. Okay. All right. Let's stop here. My wife is yelling at me.
Yeah.
Okay. Let's just go over it real quick. Um, what number were we on before?
I think we did the what do you call it? We were at Diadelphys, and then we did 12.
Oh,
We did the
12. Okay. Yeah. So the magistral. Um, Magistro's fine, but I mean, how often do you use Magistral? Like,
I don't use it a
um,
lot, honestly, and I think the indications is to use it for like
sup
endometrial
suppression,
hyperplasia,
endometrial suppression, right?
for like I thought it was for like for like EIN.
Yeah, yeah, endometrial suppression, like
Yeah,
hyperplasia suppression.
yeah.
Yeah. Um, so I will probably just know the different types of progestin that you could use, maybe.
Mhm.
Prometrium, Parvera, and then Magistral, and like a little bit of what the differences are between the three. Um, I think Pavera has a slight increase in breast cancer risk um, compared to the other one, and that's what that WHI study was. Because they used Pavera for all of the patients, and there's like an
Mhm.
increased rate of breast cancer. So I think permetrium is a little bit better in that sense. Um, yeah, and then progesterone is very potent or something like that, right?
Mhm.
And then patient 15, you said about the conservative management that was pretty good.
Mhm.
Um, yeah, I mean she wants to get pregnant, so And then I think for the secondary infertility, the only thing you forgot, I think, was the karyotype of the
Oh,
patients.
carrier. Oh, carrier type.
Of
Yeah.
the, I mean, it's a low yield cause, but it's one of the causes.
Sure.
Yeah. Um, and then 17. Yeah, so there's no thickened endometrium. You could just say like, oh, that's how the radiologist reported it, but
Right.
you understand that there's no such thing as thickened endometrium for a premenopausal woman.
Right.
But yeah, you could just say that or something like that.
Sure.
Um, and then the EMB, yeah, I mean that's fine to say that patient refused. Yeah, um, yeah, I mean that's fine. Um, anything else?
No, I think maybe next time we can go over like how can you manage the patient's pain during like an EMB, like the paracervical block and the pudendal nerve block and things like that. We can read up on that because I feel that's something they can ask about too.
On a
Do
on
you
a
want
EMB or on a
on like
DNC?
any office procedure? I know the pudendal block is more like done on labor and delivery. Someone's
Yeah.
like and
Uh-huh.
stuff.
I think you
But
could do paracervical block
do you
with
do it?
like I don't, but I've read about it.
Yeah, I read about it too. I don't do.
Okay. Yeah, we can go over that next time.
And I'll read up a little bit on like anatomy of the abdominal wall and anatomy and
Yeah.
stuff.
Mhm.
We can do that too next time. When
Yeah,
are you
sounds
free?
good.
This weekend?
This weekend, yeah, I'm pretty free this weekend. So if you want to do Saturday,
It's a Saturday. I think I have two mocks with two of my mentors from
oh,
residency.
okay,
So,
cool.
yeah, and so it's gonna be like a stressful day for me. I'm gonna,
Oh, okay,
I'm
okay.
gonna need to do that. But maybe
Um,
Sunday or like Sunday sounds good. Yeah, if
yeah,
you're able to.
Sunday. Yeah, Sunday's fine. I thought Sunday we're
Which one?
doing something with Hannah. Are we?
Oh, we are.
I don't know. Are
We
we?
can do like before or after. I think she. I'm not sure. Let me see here.
I think she
Let
said
me
like
look at
1 p.m. or something.
1 p.m. Yeah,